We're here at the SOHO meeting in Houston, and there's been some very exciting presentations. We have a section on CLL, and we know now that there's been a lot of important data that came out pretty recently at ASH last year and also at European Hematology Association meeting this year that really goes to the standard of frontline care in CLL. Some very important randomized trials. We previously had the RESONATE-2 trial, which compared chlorambucil to ibrutinib as frontline therapy for older patients or less fit patients with CLL. And that clearly showed that ibrutinib produced a much longer progression-free survival, and actually, even though crossover was allowed, an overall survival advantage was seen also. The issue with that, however, is that if you have a fitter, younger patient, your standard of care would not be chlorambucil. It would be a more effective chemotherapy regimen such as BR or FCR. And so we were all eagerly awaiting those randomized trials which came out at ASH last year. And what they showed is that ibrutinib produced a longer progression-free survival than either BR or FCR. Now, there also was an arm in one of the trials which was ibrutinib and rituximab. So that was the three-arm trial of BR, ibrutinib, and ibrutinib rituximab. And that was important because what it showed is that adding 6 months of upfront rituximab to ibrutinib did not result in any difference in long-term progression-free survival compared to ibrutinib alone. And of course, both were better than bendamustine rituximab. Now, interestingly, in the FCR versus IR trial, there was only IR. And you might think, well, why did they use ibrutinib rituximab and not have an ibrutinib arm? Well, that was a trial for young, fit patients who are the minority of patients with CLL. So they really felt that they needed a two-arm trial and would not be able to accrue to a three-arm trial, and knew that that question would be answered in the trial with the older patients where bendamustine rituximab was the control arm. And we're kind of taking a bet that because rituximab improves the outcome with chemotherapy in every lymphoid malignancy, that probably IR would be better, although that's not what we saw. But I think that we can assume that their results with IR would have been the same with ibrutinib, and again, that was significantly better than FCR. Now, one of the issues, however, is that if you look at the long-term results with FCR, what you see is that there's actually a plateau on the progression-free survival curve, but it's pretty much limited to patients with a mutated IGHV gene. And in that trial of IR versus FCR, so far, there's no difference in progression-free survival within that mutated group. So I think there's still the question of if there's a cure fraction with FCR, which many people believe, albeit pretty much limited to some of the mutated patients, will we see that with ibrutinib? So just based on the overall progression-free survival that initially is driven mostly by the unmutated patients who progress more quickly on chemo, it's hard to know if that long-term plateau will be seen with ibrutinib. It might be, we just don't have any long-term follow-up. Even the RESONATE-2 study, the one with chlorambucil, the longest follow-up, which was recently presented at EHA, was 5 years. So it's too early to see that plateau. And so we might see that plateau as time goes on with ibrutinib, but I think some people are still very hesitant to give up FCR in that fit group who are mutated because of the suggestion that there might actually be a cure fraction in that group. Of course, how much does this actually change the standard of care moving forward? That's a little bit hard to say and probably varies country to country. And the reason, of course, is the expense of ibrutinib and the relative cheapness of chemotherapy. And we know that ibrutinib is an excellent salvage agent. So if a patient gets chemotherapy, and let's say they get bendamustine rituximab and relapse 3 to 4 years later, they can still get ibrutinib and do really well. Ibrutinib still seems to perform the best in previously untreated, but the remissions in previously treated are very durable. And so that's a strategy that I think is still going to continue in a lot of countries where the drug is very expensive.